Thank you for joining us for our lunchtime webinar. My name is Karin and I'm a member of the Alumni Affairs Office in the UCLA School of Public Health. We started these monthly online forums in 2010 in the hopes of giving alumni and friends ongoing access to some of the research and happenings here at the school. The webinars are designed to be part lecture, part discussion, so we will allow time for questions. If you do have a question, simply type it in the field at the bottom of the chat window. Also, please feel free to give us feedback using the emoticons. For today's webinar, Dr. Paula Tavrow will bring us up to date on adolescent reproductive health in Sub-Saharan Africa. Dr. Tavrow is an expert in community-based approaches to improve women and children's health in Africa. At the School of Public Health, she serves as an adjunct assistant professor in the Department of Community Health Sciences and as the director of UCLA's Bixby program in population and reproductive health. Dr. Tavrow will describe how social, cultural, and economic forces in Sub-Saharan Africa heighten youth vulnerability to their reproductive health problems. She will share firsthand from a project with teens and young adults in Kenya and look at developments in HIV education and prevention. So let's get started. Paula?
Thank you, Karin. I'm delighted to be doing this webinar today with you and to share with you some of my research findings in Kenya from the year 2003 to the present. So let's get going. First, some key facts about adolescence. It's very interesting that adolescents form a very large part of the population of the world. We estimate about 1/5 of the world's population are between the ages of 10 and 19, and that's about 1.3 billion adolescents on the planet right now. Even more interesting is that most of them live in developing countries. 85% do. And also an important issue is that 2/3 of premature deaths and 1/3 of adult disease burden is associated with conditions or behaviors that began in youth. So it's a very critical time for interventions and activities so that their subsequent lives and livelihoods are optimal. When I think about adolescence, I think that the best way to describe it is a time of vulnerability. What you have is young people with still developing minds and bodies, lots of immaturity, shyness, inhibitions, but at the same time, they are exploring, they're taking risks, they're doing all sorts of things that could get them into trouble. At the same time, and particularly this is relevant in developing countries, it's a time of poverty and dependence. So according to the UNFPA, about 1/4 of youth currently live on less than $1 a day. Many of them are already trying to earn money for their families. And yet at the same time, they're very dependent on adults in their lives who serve as essentially the gatekeepers, the role models, but also can be part of the problem. And what does this mean then for adolescents? If you combine that, those still developing minds plus the poverty, it puts them at greater social and biological risk. And when we consider reproductive health issues, the #1 concern when we're talking about Africa right now is the ongoing problem of HIV incidence, in other words, new infections. About half of people with HIV are currently under the age of 25. In Africa, they're mostly young women. We also know that many youth experience unwanted pregnancies. It's estimated that 10 to 14% of all youth worldwide have an unwanted pregnancy, some of which do lead to terminations or abortions, others to early births. And of the youth who do give birth, about 4 out of 5 of those births are unwanted. We also know that when it comes to pregnancy and childbirth, that deaths during pregnancy and childbirth are twice as likely for girls age 15 to 19 than they are for those just a few years later, age 20 to 24. And in fact, the most recent information from the World Health Organization is that pregnancy and childbirth is the #1 cause of death right now for girls 15 to 19 in developing countries. So these are pretty serious issues. So when we consider youth worldwide, we know that there are a number of issues that heighten their risks for acquiring diseases and even leading to a premature death. The first is in the realm of personal issues, and by that we mean the lack of knowledge, which is particularly a problem in developing countries, low self-esteem and low self-efficacy, particularly of girls. But we do know that low self-esteem can lead youth to be more influenced by peer pressure and do things that they might regret later. At the same time, that there is a belief that they have low personal risk, that things are more likely to happen to others than to themselves, and so that also puts them in danger. There's also a number of risks that are associated with peer-to-peer issues. So, for instance, strong desire of male adolescents to be considered masculine or virile and to do things to support that reputation, which again could be dangerous for others and to themselves. There's also peer pressure for early sexual activity, particularly among young men. On the other hand, for girls worldwide, there's still this desire of many of them to be considered chaste, to be the good girl, and that also has implications. It makes them reluctant to speak out if something happens to them or if they make some mistakes and need some help. Also among youth worldwide, there's still a strong belief that condoms signify mistrust, that those people who use condoms do so because they are promiscuous. And so young people might start a sexual relationship by using condoms, but within a few times then they feel now we trust each other and so on, and they may stop using them, and that puts them in danger. Also, we know that among peers, there's quite a bit of experimentation with alcohol and drugs and other substances. And so again, not knowing what that means for you can also put you in danger. It takes time to figure out what you can tolerate and so on. From a social standpoint, we still have considerable victim blaming for date rape or sometimes called acquaintance rape or coerced sex, particularly in developing countries, that many people believe that it's the girl who provoked the coerced sex, and that is a serious problem and makes it very difficult for the girls sometimes to prosecute. But we also know that poverty itself heightens risks for youth, and that youth are doing things to get money, and so that does put them in danger. And I see that somebody has posed a question about what about economic and age disparities between men and women. We'll talk about that in just a moment when it comes to Africa. And also, lastly, that youth still lack the rights of adults, and as I said earlier, adults are the gatekeepers. Youth often have to go through adults in order to achieve certain rights, even rights to services and so on, and this can put them in harm's way. A very important conference occurred in Cairo in 1994. It was there were a series of conferences every decade on population issues, but the one in Cairo called the International Conference on Population Development was a watershed, very important, because for the very first time, adolescents were discussed and their rights were made explicit. So I'm just going to focus in on this issue that, as you can see, it says reproductive rights are the basic rights of all couples and individuals to decide freely and responsibly the number and spacing and timing of their children. But the key issue is this next paragraph. Full attention should be given to promoting mutually respectful and equitable gender relations, and particularly to meeting the educational and service needs of adolescents to enable them to deal in a positive and responsible way with their sexuality. So this was considered a watershed because, first off, it for the first time said that reproductive health and rights involve equitable gender relations, so that gender disparities and lack of respect actually impinge on people's health and well-being. And again, if you think that every word of these sorts of documents is debated, the focus here was, it said particularly, so in other words, that's important, to meeting the educational and service needs of adolescents. So not just to educate them, but also to provide them with services. By that it means like contraceptive services or sexually transmitted disease services or rape counseling or whatever the case may be, to enable them to deal in a positive and responsible way with their sexuality. By positive, that was a new word when it came to adolescent sexuality and reproduction. And so the idea was that it can be, for even adolescents, a positive experience, and we shouldn't always be looking at youth sexuality as something negative and to disparage it. And so this is an important issue, and one that we keep coming back to. And in fact, when President Bush was in office, he stated that he wanted the U.S. to pull out of its agreement with this 1994 conference, largely because of that last paragraph I just read to you, because of his belief that we should be promoting an abstinence-only regime for youth. But luckily, we didn't, as a nation, pull out of this accord. So now let's turn to African youth. And this is a chart from the Population Reference Bureau, and essentially what it's helping us to appreciate is that the share of the world's youth who reside in Africa is actually increasing. So back in 1950, African adolescents represented only 9% of the total number of adolescents worldwide. And what's expected in 2050 is that they will be about 29%, so nearly a third. Right now, I would estimate that they are about 15 to 20%. But so what we see is that their share is going to be growing, or the percentage of youth who are African are going to be growing. So now let's turn to issues related to the vulnerability of African youth per se. And the photos, by the way, that you'll be seeing in this slideshow were taken by Rebecca Morris, one of the students from UCLA who's worked with me on some of these projects, and also by Vidaline Omolo, who works with the Youth for Youth program in Bungoma District. And so here's a group of young guys who are in Bungoma District, and what's very relevant to them is the low access to reproductive health education services for these kids. And why is that? And so there are a number of reasons, but these are the key ones that we find in Sub-Saharan Africa. So first, parents consider it a taboo to talk about sex, and that's a major problem across the whole continent. We find it difficult here in the United States. Parents find it very difficult to talk about sex with kids. But in Africa, it's actually a taboo. It's considered something that you shouldn't be doing. that it's wrong, it's immoral. So you can imagine the difficulty. That would mean that if you're going to get information, it has to be from some other adult. In the past, it has been sometimes your uncle or aunt, but with the changing social dynamics, many people don't live near to an uncle or aunt, and so these young people just aren't getting any information about sex. With regard to teachers, they are generally also very reluctant to talk about sexual issues with youth. They avoid the subject, or they're very judgmental. So in my experience, even when they're given a curriculum to follow, they just jump over it, avoid certain subjects. They don't want to be embarrassed by youth, or they don't feel it's their responsibility to discuss these things with youth. So essentially, youth are not hearing much from teachers. Also, in Africa, still so many youths don't go to school after primary. So for instance, in Kenya, only about 40% of young people move on into secondary education. In some countries that I've worked in, like Malawi, it was only 7 to 10% who move on to secondary school. So as a result, if nothing is done in primary school, then you've really lost the opportunity in the educational system to talk to youth. When it comes to health providers, they also have a bias. Their bias is, again, towards abstinence generally. They are very reluctant to assist a young person, say with contraception, if they feel the young person hasn't had sex yet, because then they think that they're encouraging them. And so if a youth comes for condoms or for pills or something, their first inclination is to try to discourage them from having sex. And sometimes it can lead to some humiliation, and the young person can leave, but it doesn't seem to be then linked to them avoiding sex. Also, in much of Africa, and particularly in rural areas where I have worked, internet access, libraries is very limited. Libraries are not there. Radio services even are limited or may not be in local languages. So again, just no access to education. Then there's also a strong influence in much of Africa of the church and of elders who also are reticent to talk to young people. And lastly, abortion is illegal across virtually the entire continent except Zambia and South Africa. So again, youth don't have access to that as well. Another area where youth in Africa are particularly vulnerable is regarding gender disparities, or in other words, what makes them more vulnerable is these really striking disparities that still exist. So for instance, male youths are often considered superior, more intelligent, that they are the leaders in the society, and so that makes it difficult sometimes for a girl to negotiate and to be heard and so on. Also, in my experience, female youth have almost no access to money. And this is important because young people really do need money for various things. Some of them relate to fashion and hygiene, but also other kinds of things. And so with girls, they have all sorts of household responsibilities, generally looking after other children, cooking, cleaning, laundry, and so on, and yet they're not paid for anything. Anything that a girl's asked to do, she's supposed to do for free. Whereas with boys, when they're asked to perhaps like repair a house or run an errand, then usually they're given a tip or some small money. When we talk later about traditional male circumcision, we're going to see that that's also an opportunity for boys to get money. But this disparity in money for youth does have implications for them and makes a girl more vulnerable to do things if she thinks she can get some money for it. There's also the double standard from society concerning various behaviors, so that, for instance, boys are permitted to do things, or people look the other way if a boy might get drunk or he might engage in sex and so on. But the girl will be often punished, or punished fairly severely. So this double standard certainly continues to exist. So how do we see some of these gender disparities play out? And unfortunately, there are some very notable differences that occur in girls' health. So here's a slide from, again, the Population Reference Bureau, and it's showing HIV prevalence among young people aged 15 to 24. And what we can see is that the female youth in Africa have an HIV prevalence that's far higher than their male peers, so 3 times higher, and also much higher than the rest of the world. Part of this relates to biological vulnerability. We know that girls are more susceptible biologically, but a lot of this also has a social aspect, and the girls unable to negotiate and their likelihood of taking greater risks, or having partners who are older than them who may already be infected. So lastly, another area that I have found that really heightens the vulnerability of African youth relates to traditional gender dynamics. So what you have is, in Africa, there is more homophobia than anywhere else in the world that I'm aware of. And what it means, it seems, is that boys need to demonstrate their masculinity even earlier than they might want to or elsewhere in order to prove that they're not homosexuals. So this really strong need to demonstrate masculinity, which often takes, it translates into early sex. But at the same time, the girls cannot seem to be desiring or preparing for sex. That's considered to be a sign that the girl is a slut, or, and she could actually be treated very badly by society if in any way she seems to be wanting sex. There's also very limited social mixing or non-sexual friendships with youth of opposite sex. So as a result, they often don't know how to communicate very well, and this can also lead to date rape and other kinds of things. There are some very significant differences across the continent. So for instance, in Muslim countries and/or countries where female genital mutilation is common, then premarital sex for girls is unacceptable, and it can lead to very severe social consequences. But elsewhere, particularly in more Christian Africa, then you can find concurrent relationships fairly common, and there is more sex occurring, premarital sex. Also, among young people, coerced sex is seen as acceptable in certain situations, such as dating. So in my research, what I found was that sometimes what happens is that once the boy and girl start dating, then it's presumed that the girl cannot say no to sex, especially if she started to receive things from the boy. So what then are the specific challenges in designing programs to reach African youth, other than those issues that we already have talked about? And I love this photograph that Rebecca Morris took, because it shows one of the challenges right there, which is some of the situations of the roads in the rainy season. But first, as we talked about earlier, so few kids even get to secondary school, let alone further, and that the primary schools often lack, and as well as many secondary schools often lack electricity. They don't have libraries. In fact, only 10% of schools that I've worked in have any kind of library. Less than 1% of youth have access to internet, and in fact, whenever I have been in Kenya, youth have often asked me for my email address. I have given it out. I have yet to ever get an email back from a youth. It's just so difficult. It's expensive to get online if you're in a rural area. But also, health facilities are often inaccessible to youth because of their distance, the hours. A lot of them like to close at around 3:30 or 4 just when youth get out of school. There are costs associated with some services that are prohibitive to youth. Providers do not want to have facilities open on the weekend, so it makes it very hard for youth to access services. And also in my experience, religious organizations have strong sway over schools. So even though a school may only nominally still be associated with the Catholic Church, I mean, it still may have the name like St. Mary's or St. John's, but still it has just enough that it doesn't want to get involved with sexuality issues. And lastly, cultural traditions, and we're going to be talking about this more in a moment about traditional male circumcision, may trump health or gender equity goals. So these cultural traditions are still quite important and have to consider what their implications are. So now what I'd like to do is to start talking to you about some of my own research. As I mentioned, since 2003 I've been doing quite a bit of research in Kenya, and Kenya in 2010 had a population of about 40 million. Interestingly enough, when I started doing research there, it was more like 32 million. It has been growing very fast. As you can see, its GDP per capita is only about $775. It does have a high adult literacy rate, but the life expectancy at birth has actually fallen to 55. It had reached 60 by the year 1990, but largely due to the AIDS epidemic, it has fallen now to only 55. The total fertility rate, in other words, the expected number of children per woman, is still quite high, 4.9. And it still has a largely rural population. About 4/5 of the population is rural, which is where I have done my work. The prevalence of adult HIV is estimated at around 6%, but it's, as we'll see in a slide in just a moment, it's very different. It's very much higher in the western part of the country and also along the coast, and not so much in the middle of the country. It's estimated that about 1.5 million people are now living with HIV/AIDS in Kenya, and about 900,000 to 1 million orphans from AIDS. So here are some key adolescent health indicators that are relevant. First, this is a country that nearly a quarter of its population are in that age bracket of 10 to 19 years, which we would consider adolescents, so even more than the world as a whole. And about 12% of girls age 15 to 19 are already married. Considerably less boys are married by age 15 to 19. These girls are usually marrying boys in their 20s. Interestingly enough, and I just pulled this one issue out so you could appreciate this, but this belief that wife beating is still justified under some circumstances is very prevalent among young people. So according to a recent UNICEF study in Kenya, they found that among boys, 54% still felt that there was some circumstances where wife beating would be appropriate, and among girls, 57%, and that's an important indicator of gender attitudes. About, as we mentioned earlier, about 40% of Kenyan youth are attending secondary school, but just a small portion of those then go on to college. Right now, the estimated HIV prevalence among Kenyan youths, for girls it's about 12 to 18%, boys 5 to 7%. Those are pretty wide margins, but you can see that there is a significant disparity, at least double or maybe triple the number of infections are among young women. And but because testing among young people is still very limited, we don't have better estimates. So here is that chart I was talking to you about. This is the most recent from the World Health Organization. And as you can see in the far left, where the pointer is, that's some of the highest HIV prevalence in the world. That's greater than 40% of pregnant women who were surveyed were HIV prevalent or had HIV. The area where I have been doing my work is in Bungoma district up here, where it's considerably less, about 5 to 10%, but still extremely high. You know, when we consider that the rate in the U.S. is about 0.1 or 0.2%, so it's still extremely high. So what I'm going to be spending the next part of this presentation is talking about findings from two areas of my research. One is on barriers to effective contraceptive use in the Bungoma district, and the other is the role of traditional male circumcision in rigidifying gender norms. And I wanted to thank the UCLA Globalization Research Center here that funded most of this research. So first, in order to set up a program and to reach young people, we first felt it was necessary to do a baseline. And I wanted to share with you some important findings from this baseline study where we randomly sampled 856 girls and boys ages 11 to 20. And what you can see is that among this population, from 15 to 20% of the kids were orphans in the sense that one or both of their parents had died. And then when we asked them if they had experienced any AIDS death in their immediate family, so by that, and we told them very specifically that meant either a sibling or parent or grandparent or cousin, what we found was, as you can see, that about a third of them had already had an AIDS death among a member of their very close family. So AIDS is certainly all around them. We also asked them, and again, these were confidential surveys, whether they had ever engaged in sex. And as you can see, among girls, about 22 to 34% said that they had ever engaged in sex, but among boys, it was very high, 60 to 65. And we were particularly intrigued for young boys 11 to 15 that it was that high as 60%. Now we do know that it's possible that boys may overreport sexual activity and girls may underreport to preserve reputations. But as I say, it was done confidentially. We urged them to be truthful, and so this may represent what was really going on. So of the kids who've engaged in sex, and we asked them if the first sex was coerced, and what we found was that about 40 to 50% of girls said that that first sexual experience was coerced, and a considerable amount of boys. And we have probed this further. The poverty and the orphanhood in the area, it does seem that older women are taking advantage of some of these young boys. And so this may account for why there is this high level of coerced sex among the males. Also, risk areas if they had more than one partner in the past year. Again, these are just of the youth who have engaged in sex, but you see that a number of them had more than one partner, and also had already experienced a pregnancy or had made a girl pregnant, about 10% of them, which again sort of follows what we might expect, but it's very serious in that area where abortion's illegal and where, as we know, pregnancy is so dangerous. We did also look to see what their understanding of family planning was, and we found that there were a lot of misconceptions. So for instance, the most popular method is the injectable, or the family planning shot as it's called out there. When we asked them if they felt it was safe for girls, which we know it is, we found that most kids thought it was not safe. These are the kids who thought that it was safe for girls. And boys age 16 to 20, interestingly, had a lot more understanding of this than girls 16 to 20, but still in all, about only half thought they were safe. The ones who thought that pills don't have serious side effects was even fewer. So as you can see in the major target group, which would be girls 16 to 20, only 6% thought that family planning pills don't have serious side effects for them. And so again, that shows serious misconceptions. And even though the Kenyan government has decided that youth can get family planning services without parental consent, most youth don't believe so. And so you can see only about 30 to 40% think that youth can get family planning without parental consent. And as you know, as we said earlier, if it's taboo to talk to a parent about sex, then how in the world could you get their consent to get contraceptive services? So these are some serious misconceptions that we found at baseline. And students' knowledge of HIV, given that HIV was such a serious problem, 5 to 9% prevalence rate in that area, it was disturbing that so many kids did not think you could get HIV during your first sexual act. So you see only about half knew that you could. Also, even less thought you may not know it if you have HIV. And can't tell if somebody has HIV. Again, only half appreciated that. Most kids thought they could tell if somebody had HIV, which again puts you at serious risk. But we do see in this one that there was an age difference, that the older kids did have more knowledge about this than the younger kids. So when we looked at the kids' HIV knowledge versus their family planning knowledge, we found that actually, even though the AIDS knowledge was dubious, 62% were getting the AIDS questions correct, or that was the mean number who were getting questions correct, versus only 30% getting family planning questions correct. And that's because there just is almost no way for them to get any knowledge about contraception, but there were some HIV/AIDS educational programs going on the radio and newspapers and so on. So here, just to give you a sense of it, are some of the misconceptions about AIDS and family planning. And for instance, a kid would say, a friend of mine said, if you don't want to get AIDS, just play sex without thinking about it. Or if a youth wants to prevent getting an STI, in other words, a sexually transmitted infection, he should eat well-cleaned and well-cooked foods. Or the best way to avoid pregnancy is to swallow aspirin. So very serious misconceptions which really can put kids at risk. And then when they do venture out, if they do try to go for services, they do experience some serious problems. So who found that the provider was harsh to them, particularly the young kids. If they went, like these younger girls or younger boys, to try to get condoms, they found this real tongue-lashing, very serious response from the providers, and often didn't get what they wanted. And if they went for treatment of an STD, it was also very harsh. And so here again gives us some quick ideas of how it feels to be a youth in this region. One kid said, when you go to a clinic, you're treated so harshly, it's like an interrogation, so many questions. If I won't answer, I'm told to go away. Another one said that once I had a sexually transmitted disease, the doctor talked with me and then told me to wait. I overheard him tell his son about my condition. I felt so betrayed. I waited 2 months before I went back. So this is really tough. It's hard on kids. Or when the doctor tells the kid that your parents have to come. Again, that's not the law of the land, but then doctors don't necessarily tell the kid the truth. So anyway, I'm going to keep moving through here. So for that baseline, then that led us to design a program called Youth for Youth to provide services in the schools and the clinics. When we did our evaluation of the program, we found it had limited success. And so we wanted to know, why wasn't it all that successful? And we did a number of focus groups to try to get at what might be happening in the community that could explain what was happening and why the peer educators weren't being respected and other things. And our key finding was that the community still had very high negative attitudes about the condoms. So for instance, a parent said if a youth is found with a condom in school, he should be expelled to avoid influencing others. Another parent said any student found with a condom should be thoroughly punished. Condoms should be taken away and students punished. So the idea here, on the one hand, we were promoting condom use as a responsible approach, and yet there were so many negative attitudes. So you can imagine the conflict to a kid. And there were some transitional attitudes, some belief, for instance, that he should not be punished if he had condoms because he'd be protecting himself, or that it is useful for students. But overall, if you look at this graph where we put all the responses to all of our focus groups onto one graph, what we found was that overall, about more than half either were negative about the idea that youth would have access to youth, or actually would want to punish them. That's why we call it negative punitive. That was about 16%. So here's an area with high levels of HIV, but youth would be punished if they were found with a condom. And so when we tried to look at it as a continuum, we found health providers were starting to be promoting condoms to kids, and even male secondary students saw the value of them, but you still found parents and church leaders and even female pupils wanting males to be punished or denied. So we even found peer educators saying, well, youth should be denied. So still a long way to go on that. I just have a few minutes left, but I want us to talk a little bit about traditional male circumcision, because we also found that this was an area that people said was causing youth to get the wrong message. And in this area, sorry, I'll go back one. So this is a map of Africa showing male circumcision. Kenya, over 80% of the boys are circumcised, many of them traditionally. We don't know what percentage, maybe about half of them traditionally. But in the area of Bungoma where I was working, the Luya, nearly all the Luya boys were being circumcised traditionally in age 12 to 16. And the cost to the family would be $10 to $200, and then the boys would receive money and gifts for going through the circumcision. And when we explored this further through key informant interviews and so on, what we found was that there were very strong messages coming through to the youth. So before circumcision, they were told, you won't get a wife, you resemble your mother if you're not circumcised. But also the carrots, your family will feel proud of you, you'll be given gifts. And the typical kid would get anywhere from $10 to $40, in this very poor area. So here is the knife they use for traditional circumcision. Here is an example of a boy who's going through this, and if he doesn't cry out, if he endures it, then he says he's been told, now you're valued, you're free to make decisions, and also you have new roles. So here, by the way, are some of the gifts that this youth is being given, and you're told, though, that now you no longer sit with your mother, you should not perform household tasks, a girl will have to agree with you with whatever you say. So it's pretty serious change. And also these boys, this is how they dress, by the way, before they are ready to return to society while they're still healing. But they're told, now you're making a transition, you now have to prove that you're a normal man, your penis is sharp, you should use it. So, these young guys are told, go out and start having sex. So that's what they're getting from the community. And so they themselves start saying this to each other too, that we can run away from household tasks and we should be doing this. So this has serious implications, because on the one hand, the government and programs like Youth for Youth were trying to promote safe sex and delaying sex and so on, and then you've got these traditional circumcision, which is telling the opposite. So ongoing challenges in Kenya are still the hostility of churches and schools to sexuality, education, youth not getting factual information, policies about use of condoms still, as you can see, very ambiguous, and sometimes youth are still experiencing harsh treatment. And these male circumcision messages and ceremonies are actually rigidifying gender roles and encouraging youth to have early sex. So I just want to leave you with these few concluding thoughts. That first, we know that forming sexual identity is a key developmental task of adolescents, and that teens need comprehensive information. If they get good information services, then when they do engage in sex, it can be delinked from childbearing and disease transmission. But if they don't, then we're going to still have very high rates of disease and pregnancies. So also we need to remember it's not the adolescents who are the problem, it's the adults who are the gatekeepers in the society. And I just want to acknowledge all of the UCLA School of Public Health students who have worked on some aspect of some of this research, as well as a number of Kenyan collaborators. Thank you.
Thank you, Paula. This has been very informative and sobering at the same time. We have time for questions. We have about 10 minutes, so please type your question in the field at the bottom of the chat window. And to get us started, I have a couple of questions. If male circumcision is performed in clinics rather than traditionally, does that change any of the attitudes or practices?
Interestingly enough, when youth go through traditional male circumcision, it also has spiritual aspects. It's to show bravery and courage, and that's why they're given gifts and they're given all this encouragement about sex. If instead it is done in a clinic, then usually parents bring the kids in much younger, and it doesn't have all that other aspect to it. So it doesn't seem to have the same negative implications from a social standpoint for the kids. And yet at the same time, we know that male circumcision is very valuable as a way to prevent HIV. So there is now starting to be a shift towards encouraging more modern circumcision or medical circumcision as opposed to this traditional approach.
We have a question here. How much is the Kenyan government working towards HIV education? Ugandan government is working as a strong partner, and are they collaborating?
In my experience, in Africa, countries generally do not collaborate with each other. They have their own programs, their own approaches. With regard to Kenya, there has been this ongoing issue about whether AIDS education should include any mention of the condom. It's this constant back and forth. Unfortunately, under the Bush administration, with all the emphasis on abstinence, the government also then decided to shift to a largely abstinence program, and now they're having some second thoughts about that. But when it comes to sexuality education in the schools, the interesting thing is that you have sort of a soft government approach, in the sense that the government may tell schools that they should be doing this, but the reality is that the schools make their own decisions, or they may say that we have this religious sponsor or whatever, and the teachers feel very autonomous. So I can say that unfortunately still the kids are getting very, very limited education in the schools, which is the major place that people do pick up education. I see that there was also a question about Straight Talk in Uganda. Yes, Straight Talk has been an excellent program to try to reach kids with materials that they can understand, with easy to understand newspapers and other approaches. But interestingly enough, the Kenyan government has not been very keen to follow that lead. In fact, even a program like Youth for Youth, which we got the go-ahead from the Ministry of Health and Ministry of Education, was extremely hard to implement as an after-school program because the teachers and others would be quite uncooperative. Even though the Ministry of Education said, yes, you should go ahead with the program, they did not want to have materials from Uganda in schools and so on. So it is a difficulty.
Here's one more question. What, if any, are the benefits of traditional male circumcision?
Well, the main benefits, as I had mentioned, are that it does have this important HIV protection aspect. It does seem also that there is some community cohesiveness that comes with male circumcision, in the sense that the community gets together and then they circumcise usually a group of boys at the same time. There's a lot of celebrations and so on. But as I say, most people say, you know, it's also can be a waste of money. Some of these boys get infected. Some of the celebration involves heavy drinking and carousing. So in general, it doesn't seem that traditional male circumcision has any particular benefit over the more modern or clinical circumcision.
Dr. Elvadani is also suggesting radio as an option, a radio channel where kids can call in to open up the cultural taboo. It seems that the Kenyan government is not helping in the same way as the Uganda government. Who and how can the government officials in Kenya be educated?
Yes, regarding this issue about calling in, for poor kids, if they do have a cell phone, they use it largely for texting to call a radio program and be put on hold and then ask your question. That could use up all of your minutes. People buy minutes through these scratch cards. So you almost never hear of a kid calling into a radio program. Also, often these programs are airing when kids are in school anyway. Regarding the Kenyan government, it is very tricky, but you know, every government is autonomous and they decide how far they want to go in some directions. Uganda was way out ahead for a long time, but then is now starting to change some path. But it's a dilemma when you have governments that are not where there's a lot of conflict and people don't necessarily trust what the government says. So it's hard for them to make a big impact on people.
I find it very surprising, with such a severe AIDS problem, why do so many Kenyans still oppose youth condom use?
Yes, that's a very interesting issue, and we have probed that further. What started us on the dialogue and led to all the focus group discussions was that we heard of a youth who was supposed to be head boy but was found with a condom in one of the schools where we were operating, where he was then taken, was beaten, and was forced to relinquish the role of head boy. So we wanted to understand what is going on. But essentially, there's still a lot of people very conflicted about condom use in youth, and there's a strong view that if you don't allow youth to have access to condoms, then they won't engage in sex. So even if you have all sorts of studies to show that youth will still engage in sex even without access to condoms, still that's a general viewpoint of the community. At the same time, they don't trust condoms. They think they often break and have little holes, so they also think of them as sort of a dangerous method for people because they're not 100% reliable. So it's a little bit contradictory, but those are the main reasons that they oppose it. And I'm seeing that, yeah, in some places in Uganda, churches and mosques actually were promoting the condoms, but in Kenya it really hasn't occurred like that. In fact, the church, the Catholic Church at one point was circulating a video which supposedly showed a condom under a microscope, and there you could see little tiny holes, and they said, you see, the condom really is no good. HIV can pass through the condom. So Kenya has had quite a conflicted relationship with the condom and has been reluctant to be actively advocating its use.
Well, it seems to me that your research is very, very relevant to address these great challenges. And I also wanted to mention that Dr. Tavrow is instrumental in encouraging our students to engage in research around the world and securing scholarships for them. So I'm personally very thankful to you for that engagement, and I know many, many students are very appreciative of that opportunity to join you in the research you're doing in Africa. So thank you so much, Paula, for what you've shared with us, and we are now out of time. And I want to thank you all for joining us. We will continue the conversation on Wednesday, March 21st with Dr. Dylan Roby, who will discuss the topic, Exploring Opportunities for Innovation in Medical and the Safety Net. If you have ideas for future webinars, please type your suggestions in the chat box or email us. And if you missed any of our previous webinars, they are available on the school's website. Please allow a few days for this one to post. Have a great day.